everyone. It's really a pleasure to welcome you to the next in our series of Talks at 12 here at the Bronfenbrenner Center for Translational Research. As you know, the center is really focused on using research to address human problems. We work especially with social and behavioral science researchers to look at challenges across the lifespan. We work at linking scientific evidence with practice. We work especially on practice, outreach, education, and linkages and bidirectional linkages to science. The center is directly sponsored by the College of Human Ecology, but we're a university-wide resource. And we encourage you to learn more about upcoming Talks at 12 and other BCTR activities. You can take flyers as you go out. You will also be able to find flyers on our summer Translational Research Institute and on our workshop series, How to Conduct Translational Research, again, at the table by the door. And we would also hope you take a little bit more time to peruse our website. Just put Bronfenbrenner Center into any search engine and we should pop up. So enjoy. It's my special pleasure to introduce today's speaker. Monika Safford is the chief of the Division of General Internal Medicine at Weill Cornell Medicine. She's also in a leadership role on a university-wide initiative, the Center for Health Equity. She's building partnerships between New York City, Weill Cornell Medicine in particular, and researchers on campus. She also is building community support in both the city and in the environs of Cornell, Ithaca, extending to counties around Ithaca. And she is an innovator, a mentor, someone who is tremendously committed to community-engaged research and practice. She has developed approaches to community-partnered research, and I would say community-partnered clinical practice. So look up Monika's many, many achievements online. Again, I don't want to take any more of her time, and welcome.
Thank you.
I should also say, she had just one little, and hold your claps for this because she is really, she put Promethean effort into getting here. She had a tire that just kept leaking air. Okay, so 8 hours from Ithaca, from New York City to Ithaca, and at some point during this this talk, she may get a call from Wilcox Tire, and I think we need to let her take that call. Because we wanted to get safely on her way too.
Oh, thank you very much.
Thank you, Monika.
Thank you very much. So it's really my pleasure to be here today and share some of the work and the vision that we have for the Center for Health Equity, which, as Jennifer said, will be a university-wide center. Here are my disclosures. So what I'd like to do is talk to you a little bit about disparities in health in the 21st century, to talk a little bit about social versus biological determinants. In medicine, we tend to focus a lot on biological determinants, and I think sometimes it's shocking to biologic scientists, to see the proportion of influence. And then the importance of community partnership, with an illustration of a partnership that we developed in the state of Alabama, and how that all leads into the vision for the Cornell Center for Health Equity. So the Reverend Dr. Martin Luther King said, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. And this is really the underpinning of all the research that I have done. If we look at life expectancy in 2010, when we look at all races, white compared to black, we see that for both men and women, Black Americans have a lower life expectancy than whites. This is brought into even sharper focus when we look at these data from the National Academies of Science, where we compare people who've reached the age of 50 in 1980 to people who've reached the age of 50 in 2010. And what we've done here, rather than looking at racial differences, we look at socioeconomic status as reflected in household income. So the richest have had a lovely gain, upper middle class have had a lovely gain, and this is the slide for men. Middle-class men somewhat, but the lower middle class and the poorest have really not had much of a gain. So there has been some inequity in the improvement in life expectancy for men. And the picture is much more concerning for women, where only the richest have had an improvement. The middle income folks have had a fairly flat experience, but the lower and the poorest have actually lost life expectancy. We do have to bear in mind the starting point. So women have always lived longer than men. Sorry, guys. So the opportunity for improvement is much less for women. But I would pose to you that the decrement that we've experienced over the last 30 years is a problem that we all need to work about. So the work that I do is focused on cardiovascular disease and what we call broadly the cardiometabolic syndrome. So that includes diabetes, hypertension, heart disease, stroke. And if we look at some of the major epidemiology studies that we have in this country that are devoted to understanding what's happening with heart disease and stroke, one of them is the atherosclerosis risk in community study, or ARIC as it's widely known in the field. That reported in 2002, actually data from the 1990s, that show that the incidence of coronary heart disease, that's what CHD stands for, differs pretty remarkably across race-sex groups. So we see that for both women and for men on this slide, you can see that black women have higher incidence of coronary heart disease than whites. In the 21st century, there have been some remarkable changes since the 1990s. First of all, are the extraordinarily wide use of statins. So about 1 out of 4 American adults is on statins, and probably a lot of people in this room are included. And that has really changed a lot about the epidemiology of heart disease. We also do coronary revascularizations for people who come in with an acute heart attack. Now possible to get acute revascularizations within 45 minutes for the majority of people in this country that are having an acute heart attack. That has also revolutionized, especially the mortality associated with having an acute heart attack. That has gone down remarkably. There have also been public health campaigns, such as Healthy People 2010, now there's Healthy People 2020, where there was a recognition that health disparities should be a focus. So there have been a lot of efforts made to try to remedy the situation. Furthermore, if you look at the CDC Wonder data, these are terrific data for epidemiology researchers, publicly available free of charge. You can slice and dice mortality in a number of different ways. What we've done here is we've taken a look at the race-sex groups, and we've looked across the years at coronary heart disease deaths by race-sex group. And what you can see is for all 4 of the race-sex groups, the news looks like it's pretty good. It's going down. That's very good. However, if you put the black heart disease death number over the white, that's what we've plotted here for the 2 genders. You can see a disturbing pattern that they're really moving in the wrong direction. So it looks like disparities may actually be widening in terms of coronary heart disease deaths. So this situation prompted us to reevaluate the incidence of coronary heart disease in the REGARD study. REGARD stands for Reasons for Geographic and Racial Differences in Stroke. It's a large epidemiology cohort, over 30,000 Black and white community-dwelling adults. Everybody was 45 years of age or older at their recruitment, which occurred between 2003 and 2007. The sampling strategy was balanced on race and sex. Within the stroke belt, the stroke buckle, and the rest of the continental United States. So let me show you exactly what I mean by that. So one of the things that's really remarkable about this study is that if you were to fly over the United States and the International Space Station at night, this is pretty much what you would see. So previous approaches to epidemiology studies have required people to come to a handful of academic medical centers to be poked and prodded. Here, what George and Virginia Howard did was send a crew out to people's homes. So they invited people to participate by telephone and then partnered with an outfit that's based in Dallas, Texas that does insurance physicals in the home. So they have an army of people all over the country that does this. And that's exactly what we did in regards. Half of the sample is in these 8 southeastern states. Florida doesn't count as the South, by the way, because half the people are from New York City. But these are the 8 traditional stroke belt states, and half of this, 1/3 of the sample within this half resides in this coastal region known as the stroke buckle, which is the area in the country that has the highest stroke mortality. So the data set, by the way, for any of you who are interested, this is really an incredibly fun data set to conduct studies in. It's highly cured. We have lots and lots of years of follow-up. It's really a remarkable opportunity. We have a baseline computer-assisted telephone interview. That's what CATI stands for. 45 minutes of medical history, health behaviors, socioeconomic status. That was followed by an in-home visit where physiologic measures like blood pressure, an electrocardiogram, blood urine samples, and a medication inventory. This is one of my favorite parts. We actually opened up the medicine cabinet to see what people were actually taking, not what their doctor thought they were taking. Asked about medication adherence and also asked about their diet through a food frequency questionnaire. Follow-up is being conducted every 6 months, primarily to detect the endpoints of the study. Hospitalization records are obtained and then adjudicated by experts using a structured approach. 10-year recollection of baseline data occurred and is now concluded. Pretty much the same medical history interview that we had at baseline and in-home visits, plus some additional goodies that focus specifically on older age. So what did we find in this study that sought to update the view of incident coronary heart disease in the 21st century? What you see over on the left-hand side is the men, and on the right-hand side, the women. And we have total coronary heart disease, which is composed of fatal and non-fatal heart disease. So fatal heart disease is probably the one to focus on the most. That's when you drop dead at the first presentation. So no one knows you have heart disease and you die with your disease. So I would argue that's one that we probably need to pay a lot of attention to. But the first thing that strikes you is in the men, when you use this summary endpoint, you see that Black and white men have similar incident total coronary heart disease rates. So maybe we've vanquished the problem and it's time to go home and celebrate. Well, maybe not so fast. If we look at fatal CHD, we see a remarkably higher rate among Black men. Curiously, and this is a finding that we're still trying to understand, Black men now have a lower incidence of non-fatal coronary heart disease. We've actually gone back and you can see the same pattern in 2 other epidemiology cohorts, just wasn't recognized previously. The picture for the women is pretty different. For both total disease, fatal coronary heart disease and non-fatal, Black women continue to have higher incidence. So some curious things going on there with differences by gender. Still trying to dig into understanding that. But why is this in the 21st century that we continue to have these disparities? So this is a scary slide, I apologize, but we'll walk through it together. This was our modeling attempt to understand it. So it's an explanatory modeling exercise. What we have here are the 3 same endpoints that you saw on the previous slide. And this is the stratified analysis, men and women. And what you're seeing here are the hazard ratios from Cox models in front of the Black-white contrasts. Okay, so as I said, I like to focus on the most serious endpoint, which is death at presentation. So if you have a model that's very minimally adjusted for just age and region, what you find is that Black women have twice the hazard of dying at presentation that white women do. When you then use this rich set of covariates that are available in the REGARD study and you adjust in a sequential fashion, what you see is that by the end of that exercise, you no longer have a difference. So the conclusion that you can draw from this exercise is that this is all about these factors, which are in excess and out of balance in Black women compared to white women. So if we want to fix this problem, we have to fix this problem, which means we have to help people not get hypertension, control their hypertension once they get it, and so on and so forth. So if we look in the REGARD study at the common risk factors for heart disease, smoking cigarettes, hypertension, diabetes, poverty, we see in every case that Black men and Black women have much higher prevalence of these things than whites do. So we have our work cut out for us. One of the things before we leave the observational data that I've become very interested in is this concept of multiple vulnerabilities to health disparities that are socially determined. So we know that there is a plethora of studies reporting on Black-white differences, gender differences, sometimes race-sex differences. But there are fewer studies that ask the question, what happens if a Black woman is poor and lives in the South? So all of those things have individually been reported to be social determinants of health and associated with health disparities, but fewer studies have really looked at the cumulative effect of these within the same person. So this is the first paper that we've actually recently got published, which looks at the number of vulnerabilities here on the x-axis, and the vulnerabilities here are race, ethnicity, gender, low income, rural residents, Southeastern residents, and lack of health insurance. By the way, if you take the stroke belt, you can erase stroke and replace it with pretty much any chronic disease you want. It's always worse in the Southeast. Southeast is just not very good for your health. But we have a simple count variable here where we are showing you the distribution in the bar graph of the sample. And then here we've selected a subsample of the regards population, all of which has an indication for statin treatment according to national guidelines. So you can see that people with no vulnerabilities, about 65% of those people are being treated with statins. But if you come down here to those who have 4 or more, you can see it's only 45%. So this difference is really magnified when people have multiple vulnerabilities. We're concluding a study where we looked at incident diabetes in people who did not have diabetes at baseline, and you can see the same sort of thing. This is the incidence of diabetes for people with no socially determined vulnerabilities, which is somewhere around 10, that doesn't sound quite right, per person year. I forget what the values are here, but what you can see is that there's a more than double risk for people with 4 or more vulnerabilities. And this is the development of diabetes over a 10-year time period. So again, a very remarkable effect. Curiously, when we studied hypertension control over a 10-year time period, we did see the signal, but it was much less. So here what you see is people with no vulnerabilities. Oh, the x-axis didn't come out, I'm sorry. But this is 0, 1, 2, 3, and more. And what you can see is this downward trend, which is statistically significant. One of the nice things of working with the regards data is you always have thousands of participants. So everything is statistically significant. You actually have to think about whether it's clinically relevant. Love that. But you can see that blood pressure control was more difficult to maintain over 10 years for people with multiple vulnerabilities. But this is really a curious finding, much less pronounced signal there. And part of that is that we've done a terrific job with educating the African American community about their risk for hypertension. So pretty much in every large data set that you look at, African Americans are more aware of their hypertension when they have hypertension. They're more likely to be treated, but they're continuing to be less likely to be controlled. So we think that that may be part of the story here. So this is the donut that always surprises clinicians. So this is where I sit with medical care. And this is a fairly consistent estimate across researchers about the determinants of health outcomes. So you can see genetics is a very large component. Individual behaviors, I think that's not a surprise. But social and environmental factors probably have double the influence of what we can do as physicians in caring for people's health. So we have been very late to this recognition, and this is now becoming a very large focus in population health management, how to integrate social determinants of health and address social determinants of health in collaboration with what we do as healthcare professionals. So how do we fix this problem? Well, I would propose to you, and this is obviously a very friendly audience who already believes in this, that community partnership is a very important strategy to pursue for this. And I'd like to share with you some of what we've done in the Black Belt in the Encourage program. So who here has heard of the Black Belt? Okay, a highly educated group. Usually it's less than 10% of the audience in the North who's ever heard of the Black Belt. So it's an area that actually stretches from eastern Texas all the way up to Maryland, roughly depicted here. And it is an area that has some social, political significance. Here it is in Alabama. This is the area, it's called the Black Belt for the soil, not because Black people live there, but definitely Black people now outnumber the whites who live there, because after the Civil War, after emancipation, about half of the former slaves would move north to the cities, and the other half remained in place, and their descendants remain there today. And these are the poorest counties in the country. This right here is Wilcox County, which is often the poorest county in the United States. People in Alabama like to say, thank God for Mississippi, because there are some counties that compete for that honor on a year-by-year basis. But when you drive through the Black Belt, you really think that you're more in Africa than you're in the United States. Many people go without running water. They have wells in the backyard. They shoot squirrels for their protein. Many of them go without electricity for months at a time. And the idea, we had a PCORI-funded project where we actually had to get on the phone and explain to them why we were giving our participants portable DVD players that plug into their cars, because it was costly. And they said, well, why don't you just post the videos that you have on YouTube? And we had to educate them that if you want to go and have Mark Zuckerberg fly by with his big internet plane, that would be wonderful, but right now they just don't have access. One of the problems that we have is that this is Birmingham up here in Jefferson County, and here are our partnering communities, and this is about a 2.5-hour one-way drive. So that does pose some challenges. This is what these counties look like. So here are the 8 counties that I just showed you in the previous slide, compared to Alabama and the United States. And you can see very high proportion of individuals who are Black, very high poverty rates, often twice as high or more compared to the national average and even Alabama's average. And then here is the perfect mismatch of need and availability of resources. You can replace diabetes here with pretty much any chronic disease, and you find that 1.5 to 2 times more prevalent chronic diseases and an order of magnitude fewer primary care physicians per population than national averages. So it's a great place to study alternative care delivery models. So why are there so few physicians in the Black Belt? This is the Pineapple Federally Qualified Health Center. In the town of Pineapple, half of the town signs have pineapple as one word and the other half has it as 2 words, which really reflects the educational levels that are prevalent in the area. Here are 2 sisters of St. Joseph's, both of whom are now retired, and these were the physician and the nurse practitioner for many, many years. The fellow who took over this practice from Sister Cook, who retired finally at the age of 85, is himself 72 and has been talking about retiring for the last 5 years. So it's a real problem to get physicians to go there. And part of the reason is that this is the Pineapple Town Hall. So you can imagine that physicians or young folks coming out of training, many of whom have hundreds of thousands of dollars of debt, are unenthusiastic about going and practicing in a place like this. And this is really a crisis in rural America. This is not just in the Black Belt, by the way. Folks up here have exactly the same issues. So to make matters even more challenging, you have some additional barriers. So African Americans tend to be very private about their medical conditions. When our regards interviewers call people to find out how they're doing, if there has been a demise, they can always tell right away whether it's a Black family or a white family, because in many of the Black families, they don't know the conditions of their parents. That's very unusual in white families, but privacy around medical conditions is a very important barrier. Distance, obviously, education, we already talked about, internet availability, and trust. So this is a picture of a public health worker withdrawing blood from a sharecropper in the 1940s. And of course, this sharecropper was unwittingly part of the Tuskegee syphilis study, which was not concluded until 1972. fully 30 years after a cure for syphilis had become available. And this study has had a remarkable and profound effect in the African American community all over the country. Experimentation is just an assumption. When you go to the doctor, you're going to be experimented on. And it doesn't help that when you try to control blood pressure, in many patients, it's very difficult. So you have to titrate up and down, you have to try different agents, and the perception on the part of the patient is that I'm being experimented upon. So this is a real issue. Which is why I like community health workers. So in our studies, community health workers live in the same communities as the targeted population. Ideally, they have this chronic condition or care for somebody with a chronic condition, because what we ask patients to do that have diabetes is really a Herculean effort. We wrote a sort of a tongue-in-cheek paper a few years back where we looked at all of the recommendations in the American Diabetes Association guidelines for self-care, and we had a group of diabetes educators sit down and estimate how much time all of that would take. It's 2 hours even if you're not on insulin. So I don't know how many of you have 2 extra hours in your day to take care of your health, but most people don't have that kind of time. And it's made doubly more interesting or challenging because we love to tell people to have a healthy diet. Not only are these people used to eating and enjoy eating fried chicken, sugar-sweetened drinks, when they do have greens, they're soaked in pork fat. You know, they don't understand what quinoa is. They've never heard of that stuff, nor can they get it. And much to my surprise, most of them do the majority of their grocery shopping in the dollar store. So we glibly tell people to have a healthy diet, and that's the reality of their lives. The community health workers are terrific at figuring out solutions. Like one of our community health workers got a farm stand to move to the dollar store parking lot and started disseminating the information in their circles so that people can go there and actually get fresh fruits and vegetables. So they actually are terrific resources from that perspective. And here's a cartoon. I think most of you are familiar with this model, where the community health worker assists and supports the individual, helps them to have more productive interactions with the healthcare team, can access community resources, and hopefully achieve better health behaviors and then better health. So our first trial included 424 individuals with type 2 diabetes, and it was a randomized controlled trial, and our recruitment goal was 400. So, you know, I've just told you that African Americans are particularly distrusting of the healthcare system in general, but research studies specifically. So how did we achieve a recruitment that went 5% above our target? 80% of these people were African Americans. It's because we had community members doing the recruiting. So, you know, we recruited a couple of thought leaders, key opinion leaders who really got what we were trying to do and who also understood what these problems were doing to people in their communities. And they went out and they just, you know, rustle up a whole bunch of people to come and participate in these studies. We looked at typical outcomes in A1C reflects blood sugar control, blood pressure, cholesterol, BMI, of course, body mass index, and quality of life measures. Everybody got a 1-hour diabetes education class, very rudimentary. And the intervention was telephone delivered, you know, big distances. You don't want people to have to travel. And worked with a trained community member where they had really most of the training was in motivational interviewing to help them with behavior changes to have more salutary behaviors. Much to our surprise, we had improved blood pressure and modest weight loss. This was not a weight loss trial. If you've ever been involved in a weight loss trial, it's pretty darn hard to get people to lose weight. So this was a big surprise to us. But if you get people to lose weight, their blood pressure definitely goes down and their quality of life goes up. But there was no change in blood sugar control or cholesterol. So we said, how did we get weight loss in a trial that was not designed as a weight loss trial? One of the things that we did is we gave people at the end of this 1-hour class a report card and then said, so this is what you look like. Now you go with your community health worker and work on stuff. And much to our surprise, most of these people wanted to work on diet and exercise. And when we talked to them after the study, they said, well, you know, the medications are really a Band-Aid. I now learned that the big problem is that I'm not eating right and I need to exercise, and I really wanted to work on that. Which as a physician, you know, nothing could have been further from my expectations, because I thought, well, you know, we always say as doctors, patients want a quick fix. They want the pill. That's what they're interested in. Actually, they're not. You know, they're much more interested in durable solutions, which was a real lesson. But in terms of community partnership, one of the things that is a key is listening to what the community needs are. So I was extremely lucky to fortuitously arrive on the scene when a cancer center had been there for 20 years trying to push cancer screening. For whatever reason, these communities are much less interested in cancer than they are in diabetes and hypertension. So every time they had a community coalition meeting, they would ask for diabetes programs. And one of the first people to meet with me when I got down to Alabama was the cancer center director. And I said, well, hi, what are you doing here? Because I study diabetes. And he said, you have to bring a diabetes program. I don't want another community coalition meeting where we keep being badgered about when are we going to bring diabetes. So our Encourage trial brought diabetes, and that was part of the reason why we were able to recruit, because the community rolled out the red carpet for us. We were not coming and telling them what the problem was. They came and wanted these programs. In the course of doing the Encourage trial, as I just showed you, most of these people were trying to exercise. The most common challenge that the community health workers encountered was that their patients were in too much pain to exercise, which was very curious. I looked in the literature, and there was remarkably little about chronic pain and diabetes, other than some very specific neuropathies that occur in less than 15% of diabetic patients. So we looked back at our SF-12 scores, and one of them relates to chronic pain. 70% of these people were reporting enough chronic pain to interfere in activities of daily living. We still don't know exactly what this is due to, but the suspicion is that this has to do with obesity. People who are very obese, the average BMI of our participants was 36, are very inactive. So when they begin to become active, they experience pains and lots of sort of minor injuries as they're getting more active. But we realized that we really hadn't given these folks any tools for how to overcome pain as a barrier. So the second trial, I am not a pain researcher, was entirely focused on how to help people overcome pain as a barrier to getting exercise. And I really love this trial. We are finishing the main results paper because we actually borrowed a program and adapted a program that was developed in rural Pakistan. So here's an example of a third world lessons learned that is being applied in the United States. So it was another randomized trial, 200 participants. And here we taught the community health workers how to deliver a cognitive behavior-based intervention. So they were not therapists. They followed a very structured program, but it had all the elements of cognitive behavioral therapy in it. And the other folks got general health counseling over the telephone. So we really had some remarkable results. 200 is not a very large sample size, but these results were really spectacular. So this was at follow-up. We asked people, do you get little or no exercise despite pain? And you can see about half of the control condition participants reported, yes, they get little or no exercise. And you can see that only 17% of the intervention patients did so. We asked them, compared to baseline, do you now get more exercise despite your pain? You can see intervention much more. And did you maintain the same exercise despite your pain, and more on the intervention side? So we had terrific improved pain, depressive symptoms, stress, and all of these were remarkably sustained at 1 year, which was not expected. But again, no improvement in glycemic control. And if you don't improve sugar, you're not going to improve the long-term outcome. So the third trial focused entirely on medication adherence, and that one is still out in the field. And in the course of these three trials, we heard increasing voices from our community partners. You know, it's wonderful that you've brought us these 3 diabetes programs, Dr. Safford, but how about a hypertension program? So we are now fielding the Southeastern Collaboration to enhance blood pressure control, which is right now the largest government-sponsored hypertension trial in the field. And of course, we've turned it upside down and backwards with the new definition of hypertension that emerged 2 weeks ago. We're still trying to figure out what we're going to do about that. But you know, here the community partnership is this dialogue between the community and the researcher, where we clearly proposed studies that met needs that were expressed by the community, that I would never have done a pain study if it wasn't for that initial experience. And I think this kind of relationship is what is durable and is really enjoyable to people in the community and makes a very big impact. But in the course of that work, one of the things that really impressed me, especially in the medication adherence study, was how far apart doctors and patients are. So we did a lot of qualitative work with people finding out, what is it about medications that you don't like? After millions of dollars and 30 years of research on medication adherence, we have hardly budged the needle. About half of people with chronic diseases where the doctor recommends a medication that is proven to reduce long-term outcomes, about half of people are not taking that medication a year after that initial recommendation. And there's been just a tremendous amount of work, and we really haven't chipped away at this problem. So we decided to take a much more patient-centered approach and really try to understand the perspectives of people about what is it about medications. And what we heard was a very different set of priorities than what physicians typically want their patients to know. So the first thing that people want to know if a doctor tells you that you should take a medication, what's the first question that comes to your mind? Sorry? Cost and side effects. How much do physicians get training on cost and side effects? Almost nothing. Side effects are treated in medical school as noise that needs to be tolerated in the background in order to get the benefits of the medication. In fact, most physicians don't want to talk about side effects because they're afraid that they're going to prompt their patients to then complain about those side effects. So this is an area that really hasn't been studied at all. And it's very clear that if people don't have their questions answered, what a surprise that they decide that maybe this medication isn't for them. So I liken this situation to the physicians on the north rim of the Grand Canyon and the patients on the south rim. I've developed this little sort of parable to bring this story really home. So pretend that you're in the market for a new car. You go to the car sales place, and the car salesman asks you a few questions. How many people in your family? How far is your commute to work? Okay, I have the perfect car for you. It's the Google car. So you're confused. Why the Google car? That's the car that I can't drive. It drives itself. Why are you recommending that? Well, it decreases your chances of getting killed in a car crash by 50%. Okay, that's pretty good, but my chances of getting killed in a car crash aren't really all that high. What about fender benders? Oh, you don't need to worry about fender benders. Let me show you these wonderful electric engine under the hood. Okay, I don't really care about the electric engine under the hood. What's the ride like? Well, I can't really tell you too much about the ride, but look at these fantastic tires that this car has. Okay, I don't really care about the tires. How much is this car going to set me back? Well, that all depends on your plan. So is it any surprise that people do not take medications the way physicians recommend? So enter the patient-activated learning system. So this is a very large undertaking that I will test drive for you if we have enough time. We do. Where it is a patient education platform that is designed to be driven by patients. So we have hypertension content on here right now only, but I can't even spell. Where's the damn thing? Yes, good. So if it looks like the Google search bar, that's of course not an accident. So if a person, if the doctor has recommended this medication called chlorthalidone, the person, oops, okay, it did it itself, can type that in, and up comes a bunch of question-answer dyads about chlorthalidone. And what we've done here is really a revolutionary turn from typical patient education materials. The typical materials are very text-dense. I've shown you the numbers of people who have low education and live in low socioeconomic circumstances, or those who are the most burdened by chronic diseases and need this information the most. Text-dense, text-heavy things really are not very helpful for them. And furthermore, the content is really not the content that many patients are interested in. So from the qualitative work that we did from our medication adherence study, we actually identified the top 25 questions that people have about medications and used that to develop what we call reusable knowledge objects. And reusable knowledge objects are dyads that have a question and an answer. Let's take a look at this one. And there's a lot of liberal use of videos. There is a See the Science section. So the first thing that we do is we take the question, and then we develop a single learning objective for the answer to that question. That is then rigorously reviewed in the literature to find the most evidence-based answer. We're anticipating that very few people will be interested in this, except potentially other physicians. That then gets translated into a short answer patient-facing text. If you prefer to read, we have that option for people. But let's take a look at this video.
Are there any activities I should avoid on chlorthalidone? If you have high blood pressure, your doctor may have prescribed chlorthalidone. Chlorthalidone lowers your blood pressure, which creates less pressure, more health. You may have some questions about what activities you should avoid on your new medicine. Because chlorthalidone lowers your blood pressure, when you start taking it, you may feel dizzy or lightheaded, especially upon standing, or experience blurred vision. Because of this, when you start chlorthalidone, it's important to use caution when performing activities that require alertness, balance, or coordination, like driving, climbing, balancing, or using heavy machinery, and doing rigorous exercise like swimming, biking, or running. Chlorthalidone can also make you dehydrated, so it's important to drink plenty of water and always use protection from the sun. Usually, dizziness, lightheadedness, and blurred vision go away once your body gets used to taking chlorthalidone. And once they do, you can go back to your normal activities. So to recap, when you start chlorthalidone, you may feel dizzy, lightheaded, or have blurred vision, and you should use caution when performing activities that require alertness, balance, or coordination. But when these symptoms stop, you can resume your normal activities. Many people don't experience these symptoms at all. If you're one of these people, you can continue your normal activities. And always remember to stay hydrated when taking your chlorthalidone.
So you can see that there's a little bit of entertainment with the idea that people enjoy the experience. It's not boring. There's repetition, less pressure, more health will stick with people, so the use of sound bites. There is a single assessment question that gets at that single learning objective. And then this is sort of along the lines of the Amazon, people who looked at stuff that you just looked at also looked at this to try to draw them in. And a prominent, university-based authorship, so that people, we definitely heard in our qualitative work that they're very skeptical about a lot of information available on the internet because you don't really know what the reliability of it is. And with the pharmaceutical industry, as influential in this country as it is, people are very skeptical about how much of this is just glorified advertising. So this just gives you sort of a flavor for what we are doing with this system. See if I can continue. So it's very theory-driven. So it's Adult Learning Theory 101, short to the point, plain language, audiovisuals, interactive. There's a real attempt at patient activation by addressing the patient's priorities first. The information comes from a doctor, and we've definitely heard time and time again that is where people want to get their health information. And we've allowed this health system to evolve completely uncontrolled so that you have less and less time with the doctor. And it is free of conflicts of interest. One of the more neat aspects to this is the gaming influence. So this is an internet platform, and we are using something called Bartle's taxonomy. Anybody in the room has heard of Bartle's taxonomy? Yay! A couple of people, somebody over there too, fantastic. So this is little known and understood in public health and in medicine, but is the foundation for a multi-billion-dollar online gaming industry. And Bartle is a social psychologist who works at the University of Leeds in UK, who basically posted this online. This is not even in a peer-reviewed literature, but it really forms the foundation for every single online game. And what he did is observe hundreds of players to see how they are interacting in these incredibly instantaneously mesmerizing games. If you've never seen World of Warcraft or League of Legends, you really should take a look at them. Look over the shoulder of your teenage son, because there is something about it which is just very, very indrawing. And what he found was that there are 4 general player types. And they resonate as people, as sort of human behavior types as well. So there are the achievers, and they're in it to get the high score. These are the pre-med weenies who are arguing from a 98 to 100. And sort of the opposite of them are the killers who get their jollies by keeping the achievers from getting the high score. Those are the people who always rain on your parade. Then on the other pole are the socializers who are in it to socialize with each other. And that's the chatterbox who constantly gets in trouble for talking too much. And opposite them are the explorers who are out at the edges of the game. What happens if I jump off this cliff? You know, can I swim if I jump in this water? And those are the daydreamers looking out the window and never paying attention. So we tried to create something in the system for each of these kinds of interactions, recognizing that if this gaming industry has been so successful, perhaps we can borrow from that. So I gave you the demo. One of the big surprises, this is now 72 countries. I gave this talk in September at a conference, and we looked at the Google Analytics. If you have a website, that's really a treasure trove of data. And we had over 20,000 hits from 41 countries, and now it's up over 30,000 in 72 countries with minimal content and absolutely no marketing. So clearly this is filling a niche of some sort. So we have a small RCT that we have completed, 100 participants. Of course, we went up against the giant of online medical information, which is WebMD. And I will openly state that that's part of my intent, is to replace WebMD with PALS. Eventually, we want to have the length and breadth of medical information, including, by the way, health and nutrition information, which is #1 on everybody's list. Whenever they get diagnosed with anything, they want to know what they should eat. Again, physicians very poorly educated to provide evidence-based answers to those questions. But in this little RCT, this typical age of chronic condition patients that are coming into a primary care practice, half of them were women, on average 13 medical conditions, so fairly sick people. Half viewed the education on the PALS, the other half on WebMD. And we had 5 reusable knowledge objects that we asked them to look at. And then they had assessment questions. We called them back a week later to find out what their recall was. And we also asked them about what kind of confidence they would have to take a new medication, because, of course, one of the things we want to do is make sure that we have high confidence so that they will be able to make a decision whether to take a medication or not. Again, this was a pilot, relatively modest sample size. The immediate recall was statistically significantly better for the PALS. The 1-week recall was also better, but not statistically significant. They had enough information to talk to their doctor from both sites, but were more confident that they know how common side effects are with the PALS. And you can see just in general, the conclusion that we can draw for sure is that this is at least as good as WebMD. And there's even a signal that maybe at this very early stage, it's already slightly better. So that was, of course, very encouraging, and we are continuing to work on the project and welcome any kind of collaborators who would be interested in helping to continue to shape and hone this as we move forward. So in terms of the Cornell Center for Health Equity, we really want to try to apply these principles as we develop partnerships with the community, having dialogue with what their priorities are, not just what the statistics show, because one of the wonderful things about being in New York State is how many statistics we already have, and community needs assessments up the yin-yang. So we don't have to do that. But we have less the voices of the people in the community. What are your priorities? And just by way of example, what we're doing in New York City, the Cancer Center wants to seat itself primarily in Brooklyn because there are already 3 NCI-funded cancer centers in Manhattan. They're not going to fund a 4th one. And there are none in either Queens or Brooklyn. So there is an affiliated hospital in Brooklyn, and that is where we're going to focus our attention. And although the cancer disparities are marked, when you talk to people in the community, what they want to know about is hypertension. So how is the Cancer Center going to do their community engagement? And what we're evolving is a concept where we could hook them with hypertension and give programs that are in their priority list, and then teach them about the problems that they have, that the people in their community have about cancer. So we can sort of kill 2 birds with 1 stone. So let me stop there and see if you have any questions.
Probably around 5 questions. You know, and then we'll do a sort of soft stay down at 1 o'clock, so
sure.
we can leave. Do you want to recognize people?
Yes. Yes.
It's more like a clarification. How do you get information from WebMD? I mean, in terms of the outcomes and outreach. So the comparison, but how do you know what?
So we had people either viewed information on WebMD, and then we asked them assessment questions that tested whether they got the content that they just looked at. So that we didn't get any information from WebMD. We just found the same content on WebMD, took screenshots, and then had them look at those screenshots. Does that answer your question?
Yeah, very, very creatively.
There's a question over here.
Just, could you say a bit more about your use of community workers, how they're recruited, or how and who they are? It sounds like that was the key to effectiveness.
Yes, absolutely. So you know, we were very lucky to have walked in at an opportune time where the School of Public Health at UAB had been in the Black Belt doing sort of health promotion interventions for 10 years. As part of a CDC prevention center. And they made a strategic decision to move more into urban health for their next 5-year funding period. And they planned very carefully the extrication from their community-based infrastructure. And then I walked in right in the last 6 months when they were pulling out. And they said, you know, these are wonderful people. You can definitely use them if you, if you want for your program. So, you know, the woman who is sort of the backbone for us is a nursery school teacher. She has a high school education. So in terms of finding that, you know, key opinion leader, she is a huge influence in her community because they did, you know, community gardens and all kinds of walking programs. And she was always there as this presence, as a person who really was very committed to the health of her community. The other person that we found in the Western Black Belt was somebody that had a master's degree and had a tiny little nonprofit that was called Livingston Health and Wellness. So she was also seen as a person who was very committed to the wellness of her community. So those were our sort of key community coordinators, and they found all of the community health workers for us. We talked a little bit about what we were looking for. Primarily, they're volunteers who care about their community and want to improve the health of their community. And these 2 women had lots of friends and neighbors who belonged in that group. So it was, you know, it's finding some key people, which is, I can't tell you how to do that because I walked into that. But I can tell you that it's not easy. Because we had somebody who presented themselves and said, oh, you know, I've worked with other universities and I'd love to be a community coordinator. And we ran their CV by our community coordinators, and they said, oh no, this guy's very well known in the community. He wouldn't help you. He would be a problem. And there's no way for us to have known that. So it's, you know, finding somebody who is that kind of a person of stature is really a key to the success. But the community health workers in our hands have to live in the communities, and that's not necessarily the case. In other community health worker programs, that's not required. Yeah.
One of the things that came up in a collaboration that Elaine and I did with Mary Charlton and her group was that during the course of an intervention, this is a weight loss at this scale, intervention, people reported multiple stressful life events during that time, of this long term as you mentioned. And I'm wondering what your experience with that kind of thing is. I mean, in response to your point about being responsive and helpful about things people are concerned about. And these life events range from everything you can imagine, from losing jobs to losing apartments to arguments with children, whatever. What's your experience in that in your studies, and how do you think about dealing with that sort of thing?
So, I mean, this is the beauty of working with community health workers. So, you know, what you're describing is the reality of living in poverty. Every single day there are new stresses, and it's a never-ending story. And what they provide, community health workers are ideally situated to provide social support. So they themselves go through this because they live in that same community. They are poor as well, and somehow, you know, talking to somebody, a person like me with problems like mine, makes a huge difference. And so the Encourage study concluded in 2011, and many of the peer coaches, is what we call them, continue to be in touch with their clients to this day, way beyond the study period, just because of the connections that were forged. So, you know, that they help each other. I mean, that's basically what they do.
So, kind of directly building off of that, I'm curious the extent to which you see opportunities for kind of tying in this health equity perspective into general anti-poverty programs that are focused on, you know, addressing sort of issues of resource access, housing support, those kinds of services that may not actually directly bear on health, but would have profound consequences for health, right? And obviously that's sort of, to what extent that's sort of politically feasible, you know?
Yeah. Well, I mean, I see that as the future of population health management, because I think most people would agree that it's beyond the scope of a health system to address the social determinants of health. But what we really have to figure out is how we can partner with community organizations and community activities and initiatives to coordinate our efforts. Because, when you're talking to somebody about taking a medication and they don't know where dinner is coming from, I mean, it's just it's a ridiculous conversation. So you really, I think that there's a huge opportunity for that, and coordinating those kinds of efforts, I think, is exactly the right direction. And quite frankly, the research. Because although you may not see, like if you're looking at inequality and poverty, you may not see the direct health effects, but there are direct health effects. People who live in poverty have greater exposure to allergens and asthma. Pediatric asthma is one of the biggest problems with health disparities. Whereas Oliver probably had to leave, but poor people live very close to big highways and places where nobody else wants to live, and then they're exposed to all of these environmental toxins. So there are absolutely wonderful opportunities for collaborations.
Can you please tell us, how do you retain volunteers? Because the health workers, the community workers, they have a salary, they work for some organization. But
yes.
Can you tell us a little bit about?
So peer coaches. So these terms are sort of used very loosely depending on which context you're in. But community health workers, by and large, are employed, and peer coaches are, by and large, semi-volunteer. So we definitely give them stipends. And one of the big challenges that we had, we were very hopeful because there was some vague language in the Affordable Care Act about reimbursement for these types of activities that has never materialized. So in terms of sustainable models, this is the tragedy. We have these programs that work and that are really helping people, but there isn't a model in place where we can just sort of continue on, because there isn't an infrastructure support, any kind of billing or anything like that having to do with health or public health. So it's we can offer the model to people to consider, but in terms of sustainability and long-term implementation, that remains to be seen how that would happen.
I think we're just about at 1 o'clock. I know that Monika would be willing to entertain some conversations with folks afterwards, but I know some of you probably need to get on your way to your next engagement. Thank you so much.